Hi friends. Now, not only for your exams but also for your clinical practice, this topic of pleural abnormalities and lobar collapse is extremely important. So what we'll basically deal with in this topic is now pleural cavity, right, which surrounds the lung normally has a very thin film of fluid within it. When there's any abnormal accumulation of any, abnormality like a fluid, excess amount of fluid, it becomes pleural effusion, excess amount of air, right, it becomes pneumothorax, accumulation of pus becomes an empyema, calcification of the pleura, presence as calcified pleural plaque. So all these things we are going to discuss in this particular topic. Before we jump away right into each one of these topics, let us look at few recently asked clinical questions in this particular topic. Now, a patient presents with breathlessness, pedal edema, and basal creps on auscultation. This probably points towards a cardiac failure. A chest X-ray is done and is shown here. He's admitted in the ICU, right? And you can see on this particular radiograph, there is a very, very peculiar abnormality, almost an oval tumor-like or a mass-like, opacity which is seen in the right mid-zone there, right? But surprisingly, he's being treated in the ICU, and on the third day, the chest X-ray showed a complete disappearance of this particular opacity. Well, can it be a lung tumor? Can a tumor actually disappear like this? This is not only an imaging spotter, but also a history clincher. We'll discuss this as we go ahead. Well, I asked you whether it is a tumor. I'll say only this at this point. It is a tumor and still it isn't a tumor. What is this? We'll see as we go ahead. See here again, something which has appeared in the area of the pleural cavity that is not normal, that is abnormal. What is this? Patient presented with sudden onset difficulty, so acute onset breathing difficulty, respiratory rate is elevated, blood pressure is normal. X-ray suggests what? X-ray suggests unilateral hyperlucency. We have studied lucency means blackness, isn't it? Hyperlucency means excessive blackness with absent vascular markings. There is definitely mediastinal shift going towards the opposite side, right? Now, this is a two-step clinical, based question. The examiner wants you to look at this image, look at this history, and not only get the diagnosis, but the question is actually asking you what is the first step in the management of this patient. This is pneumothorax, not just pneumothorax, tension pneumothorax. How to diagnose it, when to diagnose it, and how to treat it is something that we are going to see in this particular discussion. Look at this image now. It's actually very difficult to predict what imaging modality this is, because this looks very different. That's true, because this is actually a very, very rarely used technique. It is an application of ultrasound. This is what is called as the M mode ultrasound image. Well, in pleural abnormalities, M mode ultrasound image creates some very peculiar appearances, right, which are given fancy names, exotic names like a seashore or stratosphere or a barcode. What this appearance is and what it means, we'll discuss as we go ahead. Now, let us start with the discussion of one of the most common entities that you will encounter in your clinical practice, and therefore it is also a commonly asked question in your exams, and that is pleural effusion. What is pleural effusion? It is accumulation of abnormal amount of fluid within the pleural cavity. I said pleural cavity normally contains a thin film of fluid, but when this fluid is excessively large in amount, it is an abnormal collection of fluid, it is called as pleural effusion. Now let us get some concepts cleared right away. This is something that we have discussed in the basic chest X-ray interpretation video, isn't it? This is just like revision. What is the best radiograph or X-ray for detection of pleural effusion? We have discussed it there. It is a lateral decubitus chest X-ray. So a lateral decubitus chest X-ray or chest radiograph is the best radiograph for detection of pleural effusion. Now, why is lateral decubitus radiograph the best radiograph for pleural effusion? Remember, fluid always behaves in a way such that it settles down to the most dependent part of the pleural cavity. So in an erect position, it will settle down along the diaphragm. In a right or left lateral decubitus position, right, it will settle down along the right and left lateral thoracic walls respectively, and that is where it is very clearly picked up. And therefore, lateral decubitus chest radiograph is the best X-ray for detection of pleural effusion. But if your examiner asks you what is the best investigation for detection of pleural effusion, remember we discussed a concept, and the result of this concept is, we know it is ultrasound. Why? Because why is ultrasound the investigation of choice for detection of pleural effusion? Because we have discussed a concept. We know that fluid is the friend of ultrasound. So wherever in the body we want to detect fluid, what will be the investigation of choice? We want to detect fluid or effusion here, and therefore it will be ultrasound for pleural effusion. Investigation of choice is ultrasound. But also remember, air is the enemy of ultrasound. So wherever we need to detect, wherever there is air, right, which is going to be present, or we need to detect air, will ultrasound be used? Ultrasound will not be used there, because air is enemy of ultrasound. And therefore in most of these cases, the best investigation or investigation of choice will be a CT. So in pneumothorax, when we study, I'll tell you that for pneumothorax, investigation of choice, overall investigation of choice will be a CT, but for pleural effusion it is ultrasound. This is the concept on which this particular question and the answers that we have discussed are based. Okay, now let us look at various radiographs and let us look at the findings that pleural effusion will present with. We'll start with typical findings that are most commonly seen and then discuss a few atypical ones. Let us start. The earliest imaging finding, right? So the earliest imaging finding on a chest X-ray in a case of pleural effusion is the classical finding of blunting of a CP angle. We have discussed in normal basic chest X-ray interpretation that the diaphragm has sharp margins like this on both sides. These are called costophrenic or CP angles, right? This is where the heart is. So these are the CP angles. Now if one CP angle gets blunted like this, it is because of there is fluid accumulating in that CP angle. So look at this particular radiograph. Now in this radiograph, look at the right side. You can see a nice sharp and acute CP angle there. As compared to it, if you look at the left CP angle here, the left CP angle appears blunted. Why? Because there is fluid in the left CP angle there. Now, when you see that there is a blunting of CP angle which is there, what is the approximate amount of fluid that you expect to be there in that particular, in the pleural cavity in such cases? Remember, the amount of fluid expected to be there in the pleural cavity is roughly around 200 to 300 cc. How is it that it is just a small blunting of CP angle which is seen on radiograph, but the amount of fluid is so large, around 200 to 300 cc? The reason lies in the shape or anatomy of the pleural cavity that we have discussed. And what is that? Do you remember in basic chest X-ray interpretation I told you which is the most deepest and most dependent part of the pleural cavity? Most dependent portion of the pleural cavity is what? Most dependent portion of the pleural cavity is the posterior costophrenic recess. So whenever there is any abnormal fluid accumulation in the pleural cavity, where will it accumulate first? It will accumulate in the posterior CP angle recess. But is it seen on a chest X-ray PA view? No. So all this 200 to 300 cc of fluid is accumulating in the posterior CP angle recess. But when the posterior CP angle recess is full of fluid, a few ml of fluid simply spills over into this lateral CP angle here, and that is what gives rise to the blunting of lateral CP angle recess. So blunting of CP angle means that posterior CP angle recess is already full of fluid, and therefore the amount of fluid is usually around 200 to 300 cc. Now just imagine what will happen if more and more and more fluid begins continues to accumulate in the pleural cavity. It will rise up and up. So what will happen? As the fluid rises up, it will create a dense opacity. But if you look at the shape of the opacity, look at the upper margin of the opacity, can you see that it is very ill-defined? And more importantly, it takes the shape like a meniscus, like this, like a meniscus on the surface of water. When you hold water within a test tube or a capillary tube, isn't it? This is given a name. This is called pleural meniscus sign. Usually it means that there is around 500 ml to 1 liter of fluid depending upon how high the meniscus is on the radiograph. So this is very classical. So it starts with the blunting of CP angle. Then as the fluid rises up, it creates a meniscus-like appearance. Now what will happen if there's close to around say 3 to 5 liters of fluid within the pleural cavity? When the pleural cavity is almost entirely filled up with fluid, the entire hemithorax would appear opaque, isn't it? So this is given a name. This is called as opaque hemithorax. See here, can you see in this particular radiograph that the right hemithorax here is appearing completely opaque or white? Because it is appearing completely white, this is also called as the white out lung. So white out lung or opaque hemithorax is a finding which is relatively very easy to pick up in your exams, isn't it? Because you'll see one entire hemithorax is appearing white. Now if your examiner asks you what is the first investigation for evaluation of opaque hemithorax, then it would be a chest x-ray. Right? But if your examiner asks you what is the investigation of choice overall, then it would be an investigation which would show you actually what lies inside that thoracic cavity, right? So which will show you whether it is enhancing, which will show you whether it is collapsed, which will show you whether it is lung or fluid, and therefore it is going to be a contrast enhanced CT, which will be the investigation of choice for detection or for characterization of the cause of opaque hemithorax. Now see, though we know that CT is the investigation of choice, is it possible on a chest radiograph, right, to distinguish between various causes of opaque hemithorax? At least we can make a try, and it is indeed possible to predict what could be the underlying abnormality. Now what could be the differential diagnosis? So these are few important clinical insights that we are going to discuss. Right, as we go through each and every topic discussion, these clinical insights are going to give you that extra edge of in your preparation whenever you practice clinically or whenever you are faced with clinical MCQs in your exams. It is these clinical insights that are going to help you. Now we have just seen that it could be massive pleural effusion which could give rise to opaque hemithorax. What if an entire lung is collapsed? It will appear white, so that will also give rise to opaque hemithorax. What if an entire lung is consolidated? So that will also give rise to opaque hemithorax, isn't it? So the basic differentials of opaque hemithorax, right, could be that the underlying predominant abnormality could be either a pleural effusion, or it could be complete lung collapse, or it could be massive lung consolidation. Now, is it possible for us on a radiograph to try and predict what the predominant underlying abnormality could be? Indeed, it is possible to do that. And see how simple this is, right? The most simple way to distinguish between them is to just identify one particular finding, and that finding is nothing but mediastinal shift. See how logical it is. If the entire pleural cavity is full of fluid, right, what will happen? This excess amount of fluid will cause mass effect on the mediastinum. So it will cause mediastinal shift. To what side it will cause mediastinal shift? It will push the mediastinum logically towards the opposite side. Right? What will happen if the lung collapses? If the lung collapses, yes, think about it. Yes, you are right. So if the lung collapses, there will be volume loss. And if there is volume loss, it will in fact pull the mediastinum to the same side. Yes, correct. And what will happen if there is massive lung consolidation? Think about it. Right, in consolidation we have discussed, consolidation usually does not cause volume loss. It does not cause mass effect. If there is no volume loss, no mass effect, why will there be a change in the mediastinum? There wouldn't be, and therefore the mediastinum will remain in the midline. So there will be no shift of the mediastinum. See how easy it is, right? So the next time when you look at a chest radiograph and you see a finding of whiteout lung, which is fairly easy to, identify, the next thing you should look for is to look whether there is mediastinal shift, or look at the position of the trachea. That will tell you mediastinal shift. Let us practice this. Look at this radiograph. I've already told you this is pleural effusion, but we also discussed in massive pleural effusion what will happen to the mediastinum. The mediastinum there will be a mass effect on the mediastinum. It will be pushed to the opposite side. Where is the mediastinum here? Just watch carefully. Look at the trachea. I am going to trace the black lucent tube of the trachea in this radiograph. See here. Can you see? This is the trachea here. And what has happened to the trachea? The trachea is basically pushed to the opposite side. So mediastinal shift is towards the opposite side. And therefore, the underlying predominant cause here, I am saying confidently, will be pleural effusion. Right? Now, I am going to give you a test radiograph and I want you to look at this radiograph and tell me what the underlying abnormality is. What is this? Look, a 45-year-old patient presents with breathlessness and cough. A chest x-ray is done here. What is the diagnosis? Now see here, this is a case of, again, white out lung, isn't it? Can you look at the radiograph and tell me that the entire right-sided hemithorax is appearing white or opaque? So this is white out lung. So if you have to know what is the cause, underlying pathology of white out lung, what you should look at? You should look at mediastinal shift. Look at the trachea. Trachea contains air, so it will appear black or lucent. Look at the tracheal position. Can you identify it? I'll draw it for you. See, this is how the trachea is coming. This is how the trachea is coming. But see what has happened to the trachea. The trachea is deviated towards what side? Towards the same side as the white out lung. So if trachea is deviated towards the same side, it means that the underlying pathology there must result in volume loss. And what underlying abnormality will result in volume loss here? Pleural effusion will cause mass effect, consolidation no change, pneumothorax will cause mass effect, pneumonectomy could be yes. So this could be pneumonectomy, right? But there's no surgical history of pneumonectomy which is given here, and therefore the most predominant underlying abnormality here is expected to be lung collapse. If there was an history, right, of pneumonectomy here, so if there was a history of any surgery which was given there, then pneumonectomy could also cause volume loss and shifting of the mediastinum entirely to that particular side. In this case, therefore, the answer is lung collapse. Yes, so it is easy enough to characterize the abnormalities in white out lung. Now, what will happen, right, if you see effusion on a supine film or an AP view? Means what? The patient is critically ill, right? So what happens? The patient is lying down on the bed like this, and you keep an X-ray film below the patient's body. So this is the X-ray film and a radiograph is shot in a supine position. Now tell me, at the very start of this discussion, I told you that fluid will always settle down to the dependent part, isn't it? So in the supine position, right, what is the dependent part? This is anterior, this is posterior. So everywhere along the posterior thoracic wall, this will be the dependent part of the pleural cavity. So the fluid will accumulate entirely in this portion here. So each and every X-ray beam which is passing through this particular part of the thorax will pass through this thick fluid layer, and therefore, do you see on this radiograph, the density of the entire right hemithorax is increased, whereas the left-sided hemithorax looks normal. Though the density is increased, if you watch carefully, it is these vascular markings which are still visible within the lung field, because this lung which lies anterior to this fluid level, this is normal lung and it contains air within it, and therefore the blood vessels within the normal lung are lined by air, and therefore you can see these vascular markings. Right? So this is how effusion basically appears on a supine radiograph. It is because the fluid layers down, along the posterior thoracic wall, increases the density of the hemithorax. But still, through that increased density, you are able to see the vascular markings, right? And that is because there is some amount of, normal lung, air-filled lung, which is there anterior to that fluid level. So this is how it looks like on a supine film. Now, see what will happen if you turn the patient in a decubitus film. Decubitus position means what? Decubitus means lying down, right? And lateral means on one side. So what is this? This radiograph here, see, this is R here. So this radiograph here is a left lateral decubitus film. And in the left lateral decubitus film, do you realize now it is the left lateral thoracic wall which will become the most dependent part of the thoracic cavity, right? Of the left hemithorax, right? Or the pleural cavity. So can you see here? There is a layer of fluid which has settled down along the left lateral thoracic wall there, and that is what, because this is very easy to identify against the lung, this is what makes a lateral decubitus film the best X-ray projection or best radiographic projection for detection of pleural effusion. This is something that we have discussed this. Now, another atypical way in which a pleural effusion can usually present is what is called as lamellar pleural effusion. Now, I am literally walking on thin ice here because with every slide that I have shown you until now, I have actually explained to you why this appearance is created. But here, I don't have an explanation because we don't know why the fluid behaves or gets collected in this way, but this is what is known to happen, and therefore these are all called as what? These are called atypical imaging findings. So lamella means what? Lamella means a thick band of fluid or thick layer like appearance, right? So how does the fluid get collected as a band or a layer? See, we have seen if this is the heart, right, and this is the pleural cavity, fluid will initially cause blunting of CP angle, then it will cause a pleural meniscus because it settles down, and then it will cause a completely opaque hemithorax. But sometimes in fluid, instead of settling down, it rises up vertically like this, parallel to the thoracic wall, and creates this thick band like or layer like opacity along the lateral thoracic wall. When it creates this band or layer like opacity, it is called as lamellar pleural effusion. Look at this radiograph. Now on the left side along the left lateral thoracic wall, can you see this thick layer or band like opacity there, right? Why is it created? Is because fluid is actually rising up parallel to that thoracic wall, and that is what is creating this band like opacity. Why does fluid behave like this? We do not have an explanation for that, but this is how a lamellar pleural effusion usually appears. So this is a lamellar pleural effusion. Fluid rises up vertically like a band. Now, there are some, specific clinical situations that the examiner will tell you in your exams, and these, I have coined a term for these. These I call as your history clinchers. They are very easy for your exam, in fact, because once you identify all these set of history clinchers, once you look at that particular history in your exam, you get the diagnosis even without an image. Right? So an image, even if it is there, it is going to help you. Even without an image, the history will literally clinch that particular diagnosis. So let us look at this history clincher. What is this history clincher? It is an elderly male who presents with dyspnea on exertion. So typical cardiac complaint, dyspnea on exertion. On examination, there are basal pulmonary creps and there is bipedal edema. So now I know where I am getting into. Right, elderly male, dyspnea on exertion is a cardiac complaint. Basal creps, bipedal edema are cardiac signs that probably are pointing towards a case of congestive heart failure. So this could be congestive heart failure. I'm thinking in that lines. On chest X-ray, what is seen? On chest X-ray, a mass-like opacity is seen. See, this is what we started this discussion with. A mass-like opacity is seen, but this mass-like opacity, right, disappears within the next 72 hours. How is it possible? If this is a tumor, right, will a tumor ever disappear like this so drastically, so rapidly? No. So it means it is not a tumor, it is something else. That is what is the diagnosis here, and this is a classic example of loculated pleural. So loculated pleural effusion. So what is this loculated pleural effusion? Let us have a look. Now see, until now I have told you that whenever fluid accumulates in the pleural cavity, it is free collection of fluid. So the fluid changes, so the fluid settles down to the dependent part. With the change in patient position, as the dependent position of the pleural cavity changes, the appearance of the pleural fluid or pleural effusion also changes. So we started with blunting, meniscus, whiteout lung. Supine, appearance is different. Lateral decubitus, it layers down along lateral wall, right? So most of the times pleural fluid is free, but sometimes the pleural fluid can get trapped. When it gets trapped, it is called loculated pleural effusion. Where can it get trapped? The most common site where the fluid can get trapped is within the fissures. Because in a fissure, there are two layers of pleura. In between those two layers of pleura, there is a potential space. And in that potential space, fluid can get accumulated. When it gets accumulated in the pleura, it creates an oval, well-defined opacity that actually looks like a mass or a tumor. This typically occurs in cases of congestive cardiac failure. Why? Because in congestive cardiac failure, there is a back pressure on the pulmonary vasculature. So pleural effusion is associated with congestive cardiac failure. Sometimes if this fluid gets trapped, it creates this mass-like opacity. Now, why is this mass-like opacity not a tumor, but actually loculated pleural effusion? The reason is that, right, a tumor will never have such sharp, well-defined margins. Only few benign tumors will have these. Next, look at this opacity. Do you realize that it is oval shaped or egg shaped, right? It is oval shaped, and the long axis of that oval is perfectly along the position of a fissure, or the normal position of the fissure. The long axis is along what? It is along the horizontal fissure. So it is oval in shape, long axis along the horizontal fissure. So what happens when the patient is treated? Now, when this patient is treated, right, in the ICU with, say, diuretics, inotropics, it is a patient of congestive cardiac failure, the cardiac function improves, ejection fraction improves. When the cardiac function improves, right, this back pressure on the pulmonary vasculature goes away, and the cause of pleural effusion has gone away. So the pleural effusion will also be gradually resorbed, and this therefore disappears in the next 3, 4, 5 days. And because it disappears, it is given a very, very typical name. What is it called as? It is called as a phantom lung tumor, or a vanishing lung tumor. So what is a phantom lung tumor or a vanishing lung tumor? It is a loculated pleural effusion which disappears in a few days because the cause has been eliminated or removed. So this is the important history clincher as well as imaging clincher of vanishing lung tumor, phantom lung tumor, or loculated pleural effusion that I want you to know. Now, when we started this discussion, I told you that the overall investigation of choice for detection of pleural effusion is going to be ultrasound, because fluid is friend of ultrasound. We have discussed this in the ultrasound interpretation module as well. How does fluid appear on ultrasound? Fluid appears hypoechoic or anechoic, depending upon whether it is clear or turbid fluid. So it appears hypoechoic or black. So see, this is the liver parenchyma. On the upper surface of the liver is the diaphragm, right? This here is the pleural cavity. So all this black area or the hypoechoic area that you have here is nothing but the pleural effusion. This is how it will appear. So it can detect as little as around 5 to 10 ml of fluid, abnormal fluid collection, which has just started to occur, right? Another utility of using ultrasound is USG guided thoracentesis or aspiration of pleural fluid can be done, and then that fluid can be examined, right? As well as when you aspirate the fluid in certain conditions, right, it will relieve the mass effect, so it will cause rapid lung expansion that will help the patient. So that is the use of ultrasound. Now, can CT detect pleural effusion? Of course it can, but because X-rays and ultrasound, can very easily, detect and diagnose pleural effusion, CT is never usually done for a diagnosis of effusion. But if we suspect some malignancy, say pleural nodules or deposits causing pleural effusion, or say, for example, we want to look at a loculated pleural effusion, which may not always be seen, right, on ultrasound, right, if it is on the inner sides, right, so in such cases CT scan can help. How does effusion usually appear? Again, on CT, see if it is a free fluid within the pleural cavity, it will settle down to the dependent part. So see here, this is a CT image here. Here, if you see in this CT image, right, we know this is always right, this is left. See, these are the ascending aorta, this is the descending aorta, this is the main pulmonary artery which is dividing into the right and the left. Now, if you look at this particular image here, in this image, look in the right heavy thorax. Can you see this, slightly hypodense appearing, hypo to isodense appearing area there. What is this? This is all fluid within the pleural cavity, right, which has settled down to the dependent part. Now if you watch carefully here, in most cases in pleural effusion, right, you won't see any enhancement around it, right? So there is absolutely no enhancement usually seen unless there is superimposed secondary infection or inflammation, right? There is no enhancement in the pleural effusion. When pleural fluid will get infected, it no longer remains pleural effusion. It is called empyema, and an empyema usually shows enhancement. Can you see the difference here between pleural effusion here and empyema here? What is the difference? See, pleural effusion is usually free collection of fluid within the pleural cavity, whereas an empyema is usually a loculated collection, right? Now, therefore, because it is free, right, pleural effusion is usually seen in the most dependent portions of the pleural cavity, whereas an empyema can also be seen in the non-dependent portions. As I told you, in pleural effusion, in most of the cases, there is no enhancement which is seen when you inject contrast, but in cases of empyema, because it is pus, it is loculated, there is inflamed pleura around it, this pleura always shows enhancement. So there is always enhancement which is seen, right? And this enhancement gives rise to a typical appearance, a named sign in empyema, and that is called as the split pleura sign. What is this split pleura sign? Let us have a look. So look at this particular image. This is the same image that we were looking at in the previous slide. See, this is the right side, left side. Look along the right lateral wall, not in the dependent portion, but along the lateral thoracic wall, there is a fluid collection which is seen. But if you watch carefully along its walls on both sides, what do you see? Can you see a slightly bright enhancing line there? Along the outer wall also there is a line which is seen there, right? So what is this? This is actually a pus which has been loculated, or which is collected in between two layers of pleura, and it has actually separated the two layers of pleura. On the outer side is the parietal layer of pleura, whereas on the inner side is the visceral layer of pleura, and this empyema, that is the collection of pus in between them, has split up or separated these pleural, parietal and visceral layers, and therefore it is called as split pleura sign. So the split pleura is enhancing because there is infection and inflammation along its margins, and it has been separated, right? So this is what is called as the split pleura sign. Now we have discussed the various imaging appearances, spectrum of appearances in pleural effusion, right? That is fluid accumulation in the pleural cavity. Now let us look at pneumothorax. This is an absolutely important condition for your exams. Almost every year, right? Be it your NEET exam, be it your INI set exams, be it your FMG exams, and therefore by extrapolation, be it your upcoming next exam, right? Whenever it would be conducted, right? A question would definitely be expected on pneumothorax in one way or the other. Lots of different types of questions have been asked. Let us start with the basics. Do you remember we studied an important concept? Fluid is friend of ultrasound, air is enemy of ultrasound. And here we want to detect what? Pneumo means air, and therefore the overall best investigation is going to be, we know, is CT. Remember this as a general rule. Wherever in the body you want to detect minimal quantities of fluid, the investigation of choice will be ultrasound. But wherever in the body you want to detect minimal quantities of air, what will be the ultrasound? Air is enemy of ultrasound. So wherever ultrasound fails, what will you use? You will use CT scan. So pneumomediastinum, investigation of choice is CT. Air you want to detect. Pneumothorax, investigation of choice is CT. Pneumoperitoneum, the investigation of choice is CT. But if your examiner can ask you what is the best radiograph or X-ray for detection of pneumothorax, the best X-ray for detection of pneumothorax is a chest X-ray PA view done in expiration. Remember, we have discussed the indications of expiratory chest radiograph, right, in basic chest x-ray discussion. Do you remember? That is where we first thing that we discussed, first most important diagnosis that can be made in an expiratory chest x-ray is pneumothorax, right? So best x-ray, best radiograph for detection of pneumothorax is chest x-ray PA view done in expiration, right, whereas the overall best investigation is CT. Now the question is, why is expiratory chest x-ray the best radiograph? Now, though this might not be asked in your exams per se, it would be great to have a conceptual understanding of why this particular radiograph is useful. It is very simple and interesting. See how simple the concept is. I have coined a term for it and I call it as the bread butter brunch. Bread butter brunch. So what is this bread butter brunch? See here now. Just imagine that you have two blocks of butter. So you have two blocks of butter. Just imagine that they are same in size. Both these blocks are same in size. You have two bread slices. One of them is a large regular sized slice, but the other one is only half of its regular size. Now all I want you to do is to coat this butter as a uniform thickness layer on this bread slice. So what will happen? When you coat this butter as a uniform thickness layer on this bread slice, you will get a thin uniform layer like this, because this is a big slice, isn't it? But when you coat it on a smaller slice, what will happen? Naturally, you will get a much thicker layer. Isn't it? This is quite logical. Now, the first example that I've given you in this particular situation here is inspiration. The second situation here is expiration, right? The amount of butter here was equal in both inspiration and expiration. What is this butter? This is nothing but the air in the pleural cavity. That is the pneumothorax. So does the amount of air in the pleural cavity or pneumothorax change in inspiration and expiration? No, it does not. But what changes is the size of the bread slice on which it is coated. So what changes is nothing but the surface area of the inner thoracic wall. Surface area of the inner thoracic wall. So see, in inspiration, as the chest cage expands, the surface area of the inner thoracic wall increases. So it is like this larger bread slice on which that amount of butter is now spread out as a thin layer. So the amount of pneumothorax would appear very, very thin. But when in expiration, the chest cage retracts, the surface area is going to decrease, and when the surface area decreases, the same amount of butter or air will appear as a much thicker layer, and therefore it will be easy for us to pick it up. And that is the reason why an expiratory view is considered to be better for detection of pneumothorax. This is the concept. Now let us jump to the imaging appearances of pneumothorax. See, the diagnosis of pneumothorax is relatively easy, but your examiners want you to pick it up very well along with the direct and indirect signs, because the treatment depends on the presence or absence of these signs. So let us have a quick look here. What do you see here in this particular radiograph? Firstly, if you compare the right and left hemithoraxes, the first thing that you see is this sharp line that you see in the left hemithorax, isn't it? What is this is nothing but the surface of the lung. So the lung surface is lined by what? It is lined by the visceral pleura. So this appearance of a sharp line is called as visceral pleural line. What is the visceral pleural line? It is nothing but the pleura which is lining the lung surface, because now there is air beyond it in the pleural cavity. Differential radiographic density theory creates a sharp margin, and therefore this particular visceral pleural line is seen. Next, look at this area here. How is it appearing? It is appearing jet black, excessively black, isn't it? So that is called hyperlucency, right? Lucency means blackness. Hyper means excessively black, so hyperlucency. And if you watch carefully, right, in the right lung field, you are able to see the vascular markings in this area of the pneumothorax. There are no vascular markings. So hyperlucency with absent vascular markings. This is important because a normal lung can also sometimes appear lucent or black, but inside a normal lung they will always see some vascular markings. But in a pneumothorax, in the pleural cavity, there are no blood vessels, so there will always be hyperlucency along with absence of vascular markings. Now next, tell me, pleural cavity normally contains what? We've discussed it. It contains a minimal amount of fluid, isn't it? Now if this minimal amount of fluid is replaced by excess amount of air, what will it do? This expansion of the pleural cavity is going to create some mass effect. Mass effect in the form of what? Mass effect. This excess air will push the mediastinum towards what side? Can you see here? The mediastinum has been pushed towards the opposite side. So this is the next finding. So there is going to be mediastinal shift towards what side? It is going to be always towards the opposite side. Yes, it is always going to be towards the opposite side. Next, if it is going to push the mediastinum, it will also push the diaphragm. Look at the diaphragm levels there, right? See, this is one diaphragm. This is the left-sided diaphragm. Can you see that the left-sided diaphragm is slightly pushed down, and this costophrenic angle sulcus is appearing slightly deep. This is given a name. This sign is called deep sulcus sign. This is what? Nothing but the air creating mass effect on the diaphragm. And if it pushes the mediastinum, if it pushes the diaphragm, it will also cause a very slight hyper expansion of the rib cage. So if you watch here carefully, look at the distance between two adjacent ribs on the right and compare it with the distance between two adjacent ribs on the left. You'll find the left-sided ribs are slightly expanded. So this sign is called expansion of the rib cage. Expansion of the thoracic cage or the expansion of the rib cage. Now can you see these findings in this image? Can you see the visceral pleural line? That is the lung surface. Can you see the pneumothorax appearing excessively black with absent vascular markings? Mediastinal shift is always towards the opposite side, right? Diaphragm is pushed down, that gives rise to a deep sulcus sign and the expansion of rib cage. In every case of pneumothorax, right, you must always make it a point to look for all these findings. Why? Because if you look for them and you find that the last three findings are more prominently seen, then your diagnosis changes. How does your diagnosis change? If the signs of mass effect on the mediastinum, diaphragm, rib cage are more, then the diagnosis is not just pneumothorax, but it becomes tension pneumothorax. Remember, this is therefore important. What is tension pneumothorax? Is it when the patient is in a state of tension? No. Is it when the treating doctor is in a state of tension? Well, yes, the doctor has to be, because if the doctor is not in tension, the patient may lose his life. Why? Because this is a potentially life-threatening situation. In tension pneumothorax, there is a one-way valve mechanism. One-way valve mechanism that exists from the lung into the pleura. So what happens? During inspiration, air enters from the lung into the pleura. But it is a one-way valve. So can this air go out of the pleura into the lung again? No. So with every breath, right, the pleural pressure is increasing because more and more air is entering into the pleura. What is the normal pleural pressure? It is negative. So when excess air enters into it, pressure will increase. From negative, the pressure will become 0, right? When still more air enters into it, from 0, the pressure will become positive, even more than the atmospheric pressure. What will this excess pressure in the thoracic cavity do? It will not only compress the lung, so there will be respiratory compromise, but it will also compress the SVC, IVC, so venous return will be blocked, cardiac output will be blocked, and the patient will collapse and die. And because this is a potentially life-threatening condition, your examiner has very frequently asked a question about the treatment of tension pneumothorax. Before we go there, look at this particular image here. Now in this image, again, if you watch carefully, there is a very faint line which is seen, which could be the surface of the lung here. But can you see the entire right hemithorax here is appearing jet black? There are no vascular markings. Is there a mediastinal shift to the opposite side? Yes. Is there a deep sulcus sign which is there? Yes, there is definitely there, and therefore this is right-sided tension pneumothorax. Now what is the treatment of tension pneumothorax? Remember, the treatment is in 2 steps. So it is the first step of treatment and then the next second step of treatment. What is the first step of treatment? Because it is an emergency, ideally the treatment of pneumothorax is an intercostal drain insertion. But here you don't have time to do that, right? So what do you do, right? Because this is a critical life-threatening emergency, what you do simply is you put a needle in that particular thorax, and this is called as the needle thoracotomy. Needle thoracotomy. So what is needle thoracotomy? You put a needle. Where do you put a needle? This is also a potential question. In adults, the needle is usually inserted in the 5th intercostal space, either in the mid-axillary line or just anterior to the mid-axillary line. 5th intercostal space, mid-axillary line. Whereas, that is in the triangle of safety. Whereas in children, the needle is inserted usually in the 2nd intercostal space, right, in the mid-clavicular line. So remember, A for adults, mid-axillary line, C for children, mid-clavicular line, right? So that is where the needle is put. Now what will happen when you put a needle? Now when you put a needle in this thorax, that needle will create a communication between the atmosphere and the pleura. Remember, the pleural pressure is positive, much higher. So what will happen? Along this pressure gradient, air will come out. Until the time, this will continue until both pressures will equalize. So until this pleural pressure will become 0, atmosphere pressure is 0. Now you have relieved the tension component of the diagnosis, isn't it? Tension is relieved. Now what remains is plain pneumothorax. And what is the treatment of plain pneumothorax? Definitive treatment of plain pneumothorax is an intercostal drain insertion with a water seal, underwater seal at its outer end, underwater seal at its outer end. Right? So that is what is the management of tension pneumothorax. Remember, tension pneumothorax is a very important condition. Multiple questions have been asked either this way or that way, right? Either about the diagnosis, either about the imaging features, either about the management, and therefore this is something that you must know. This is tension pneumothorax. Now sometimes as fluid can get loculated, the air can also get loculated. So if you see here, this is where the air has got loculated. So this is nothing but a case of loculated pneumothorax, right? Nothing special about it. This is loculated pneumothorax. Now how will pneumothorax look like on CT? Because we discussed what is the investigation of choice for pneumothorax. It is going to be CT. Air is enemy of ultrasound. So wherever you want to detect air, investigation of choice will always be CT. So see here, this is a lung window image. And on this lung window image, right, this is right side, this is left side, this is the left lung, which is normal. This is the right lung, see it is collapsed, and this sharp surface is going to be the visceral pleural line, which would be seen on a radiograph. And beyond the lung, in the thoracic cavity, you are seeing a jet black area. What is that? This is nothing but air within the pleural cavity, and this is how pneumothorax will usually appear on a CT images. So this is right-sided moderate pneumothorax. Yes. Now look at this condition. What is the diagnosis? See, there are some, overlapping features, some features that we have already seen. Can you see a sharp line on the surface of the lung? This is visceral pleural line. Can you see this jet black area with absent vascular markings? What are these areas here? This could be some segments of the lungs which would be there. But there is a jet black area, hyperlucency with absent vascular markings, right? But here, though this looks like pneumothorax, look at the dependent part. Can you see the right-sided diaphragm? No. What do you see, in fact, is a horizontal fluid level. Do you remember in pleural effusion, I told you that you see a margin of fluid which is very indistinct and like a meniscus like this. That is called meniscus sign of pleural effusion. But remember, whenever in the pleural cavity, you see a perfectly horizontal air fluid level, air fluid level, air above it, the fluid below it in the dependent part, and a sharp horizontal level, then remember the diagnosis is hydropneumothorax. Hydropneumothorax, right? So when you see a horizontal discrete air fluid level within the pleural cavity, it is always a hydropneumothorax. So this was also asked in one of the FMG exams. Again, similar finding you will see on CT. What are you seeing on CT here? See, this is right, this is going to be the left, this is the normal left lung. See, this is the right lung, this is going to be the visceral pleural line there, but in the pleural cavity you are seeing air, you are seeing a white appearance here because of fluid, and you are seeing a perfectly horizontal air fluid level. So again here the diagnosis is going to be hydropneumothorax. So again this is hydropneumothorax. Yes, so this is what is hydropneumothorax. Now friends, look at this video that I have here for you. Now in this particular image, right, the upper half of this particular image here, these are nothing but your chest wall layers. Now this is an ultrasound thorax, video clip that I'm playing here for you. These are chest wall layers. Where the chest wall ends, you can see a bright line there, and this, everything beyond it is nothing but the lungs. Now a bright line that you see in between those two ribs there is actually called as the pleural line. Now look at the video. Can you see that there is a constant sliding movement which is seen at the level of that particular white line? Right? What is this? Now this is called pleural line because this is where the visceral and the parietal pleura are going to touch each other. If this is a normal lung, what will happen? In this normal lung, right, the lung is going to expand in inspiration. It is going to retract in expiration. So with inspiration it will expand. Right, with expiration it will retract. So inspiration, expiration, inspiration, expiration. So with every breath you will see a sliding movement like this. This is called pleural sliding that you are able to see in this video, and this is a feature of normal USG thorax. Right, now what will happen, tell me, if there is pneumothorax? If there is pneumothorax, see, the visceral and parietal pleura will be separated. The area between the visceral and parietal pleura, right, will be filled up with what? Will be filled up with air. So the appearance will remain the same. But tell me, in pneumothorax, will this air between the visceral and parietal pleura, will it move up and down with inspiration and expiration? No. So in this video, what you are seeing here is a normal pleural sliding. Normal pleural sliding. But this pleural sliding will be absent in cases of pneumothorax, right? Because the air will not move up and down. That is the point of looking at this sliding movement there. So this is pleural sliding, right? This will become absent in pneumothorax. Now, right, so this was the video that we saw. Now on M mode, now we have discussed in ultrasound basics, if you remember, M in M mode stands for what? M in M mode stands for motion. So it detects motion. Now when an M mode is applied to a normal USG thorax, right? So this is a normal patient. This is the type of image that you see. This was asked in your exams. So what is this? These layers, these lines that you see here, these look like the waves, and these are created by the chest wall movements during inspiration, expiration. Beyond it is entirely the lungs, because air is enemy of ultrasound, right? What happens is that it gives rise to a very uniform, granular sand-like appearance. So this looks like the sand on a beach, right? This is created by lungs. So this wave-like appearance and sand-like appearance, this appears as if, right, this is a seashore, and this appearance is therefore called as the seashore sign. This is called as the seashore sign. So seashore sign is seen in what? It is seen in normal cases. on what? On M mode ultrasound, where the chest wall creates the waves, whereas the lungs create the sand-like appearance. Now we have already discussed in pneumothorax, right? You will see the pleura, but the pleural sliding will be absent, because we have discussed this air within the pleura will not move up and down with inspiration and expiration. Along with this, there are normal comet tail artifacts in the lungs. So comet tail appearance of normal lungs will also be absent. Now, so pleural sliding will be absent, comet tail appearance of the lungs will also be absent, and there are some positive signs which have been described. These signs are called as stratosphere sign, barcode sign, or lung point identification sign. Let us look at them. Now look at the first image of the seashore sign here. If you remember, I have told you that this is seen in normal patients, right? Normal USG thorax on M mode. So both these signs are seen on what? They are seen on M mode ultrasound, right? Where the chest wall layers creates the waves and the lungs create the sand-like appearance, and this is called as the seashore sign. Now in pneumothorax, this appearance changes to a completely striped line-like appearance, and this is given a name. This is called stratosphere sign or barcode sign. So remember, seashore sign is seen in what? Seashore sign is seen in normal USG thorax on M mode, whereas stratosphere sign or barcode sign is this striped line-like appearance, line after line, which is seen. This is seen in pneumothorax. There are a few more differences which are observed. Normally, when we do USG thorax, now we see these comet tail lines, right? We discussed comet tail lines will become absent in pneumothorax. So what are these comet tail lines? These are called B lines. They are seen in normal lungs. See here, if these are the two ribs and this is the normal lung. Can you see these white bright lines, hyperechoic lines, which are, going, across the image like comet tails? So this is what is called as the comet tail like appearance, or B lines, which are seen normally. We have seen already discussed in the findings that in pneumothorax these lines are absent. In fact, they are replaced by horizontal lines like this. These are vertical lines. B lines are vertical. We are seeing it here, and A lines in pneumothorax are multiple horizontal lines which are seen, right? These are called as A lines. So just to quickly summarize, right, the pleural sliding is seen in normal patients, that will become absent in pneumothorax, right? We can see the comet tail lines or B lines which are vertical normally, but they will be absent. In fact, they will be replaced by horizontal or A lines in pneumothorax. Normally on M mode, we'll see the seashore sign or seashore appearance on M mode USG in normal cases, whereas in pneumothorax, this seashore sign will be replaced by stratosphere sign or barcode sign. Yes, now see here, a patient with road traffic accident came with tachypnea and tachycardia. M mode ultrasound shows barcode sign. So M mode ultrasound shows barcode sign or even stratosphere sign, right? Then the diagnosis will be what? We have just seen these images, barcode sign or stratosphere sign. Then the diagnosis is going to be pneumothorax. Yes, so this is about the seashore sign in normal cases and barcode and stratosphere sign seen in pneumothorax. Now, sometimes the pleura can get calcified. So do you realize that until now we have seen accumulation of fluid within the pleura? Right, we have seen accumulation of air within the pleura, pneumothorax, right? Fluid will be pleural effusion. Now, pleura can get calcified. Now, does it get calcified routinely? The answer is no. It is usually due to some occupational exposure, and most commonly this is related to asbestos exposure. And asbestos, remember asbestops, so it is mainly seen in the lung bases. That is how you could remember it, right? Now this gives rise to a sign. Now if you look at this particular images here, see, along the pleural surface you are seeing a dense calcified pleural plaque, mainly in the lower part. Here also it is more thicker and more prominent in the lower part, but it is now extending extensively across the pleura, right? So this is what gives rise to an appearance. This is how the holly, leaf is, and this is why it is given a name. This is called as the holly leaf sign, which is seen in calcified pleural plaques seen in asbestosis. Though it can be identified, on a radiograph. On a radiograph, naturally, you will see them only when these plaques are large. If these plaques are smaller, right, they will be earliest or best detected on CT scan. So the investigation of choice or best investigation for identification of pleural plaques is going to be CT. Right. Now we jump into an important topic for your exams, which is called as lobar collapse. Why is lobar collapse important? Is because a couple of questions have been asked recently on lobar collapse. These were based upon the direct and indirect signs of lobar collapse. And also, this topic contains multiple named signs and appearances. And that is something that one thing you must also know for your exams. Now, let us start let us start with the discussion of this topic, how individual lobes get collapsed usually. Now, for that, we must know which lobe is located where. So, see, this is the right lung. This is the left lung. Right lung is divided into 3 lobes by 2 fissures. One is the oblique fissure that runs obliquely. The other is the horizontal fissure. So we have 3 lobes, right upper lobe, right middle lobe, right lower lobe. On the left side, there is only one fissure we know, that is the oblique fissure that divides the left lung into an upper lobe and lower lobe. Now, when a lobe actually collapses, right, what happens? Now, when a lobe actually collapses, there will be 2 things that will happen. One is that there will be volume loss. So, the lung will retract. If the lung retracts because of volume loss, what will happen? It will shift adjacent structures. The fissures within the lungs would get shifted. Diaphragm may get shifted. Mediastinum may get shifted, right? That is what can happen because of volume loss. And secondly, because the lung is collapsing, it is going to lose all its air within the alveoli. So when air is lost, what will happen? There will be a density change. There will be a change in the density. So normal lung is what? Air density, but a collapsed lung is all soft tissue, so that will become water density. So these 2 things will happen. Now, though in lobar collapse, remember, the initial investigation that can be done, and we are going to discuss this, mainly is chest X-ray. But if your examiner asks you what is the overall investigation of choice for diagnosis of a lobar collapse, then it is going to be contrast enhanced CT. Why? Because not only will it show you the lobe which has collapsed, more importantly, it will show you what is the underlying cause of collapse. Whether it is a cancer, whether it is a tumor, why is it collapsing? Right? That is something that you will get on CT. Now let us start with what are direct signs and indirect signs. This was one of the questions which was asked. It asked all of the following are direct signs of lobar collapse except, so this was the question. So you must know what are direct and indirect signs. One easy way to remember it is to remember that everything that happens within the affected lung are direct signs. Quite logical enough. But when that lung collapses, whatever happens around it or around the affected lung are indirect signs. Right? Simple enough. Now let us look at what happens actually. First thing that will happen, we have already discussed this, is loss of aeration. Right? Loss of aeration. So air will be lost. So what is the result of it? There will be a change in the appearance or in the density, right, of the appearance of the lung. So the density will become white. It will become water density. That is what will happen. Next is, because the lobe is collapsed, what will happen to the affected part? Adjacent fissures. Fissures will get displaced. So there is a displacement of fissures. Displacement of adjacent lung fissures, right? Next, what will happen? Because what will happen inside that lobe which is collapsed, there are blood vessels. If the lung collapses, there will be a crowding of blood vessels, right? So there will be a crowding of blood vessels. So what is happening in the affected lung? These are direct signs. Loss of aeration, so change in density from air density to water density, displacement of fissures, and crowding of blood vessels. In these signs, remember, it is this sign of displacement of adjacent fissures is considered to be the most reliable sign, most reliable chest x-ray based sign of lobar collapse. So this is another potential MCQ. What is the most reliable sign? It is displacement of adjacent fissures. Now, whenever a particular lobe collapses, what happens around it are indirect signs. So what will happen? All adjacent structures can get shift. There could be shift of mediastinum. There could be elevation of diaphragm, again shifting of the diaphragm. Elevation of diaphragm, this creates certain signs like juxtaphrenic peak sign. Few such signs are created. We'll see them as we go ahead. There could be shift of the hyla. So there could be a hilar displacement. If upper lobe collapses, the hilum may go up a little bit. There could be crowding of ribs. So there is rib crowding that could occur. And when one lobe collapses, the other lobe tries to compensate for it. So there could be compensatory hyperinflation. So these are direct and indirect signs. Remember just the direct signs, that what happens in the affected lung. What happens? Change in density happens, displacement of fissure happens, crowding of vessels happen. Everything else that happens around the affected lung are basically indirect signs. That is how you could remember it. Now let us look at certain classical lobar collapse patterns and the various signs that are created. So see, how does a right upper lobe collapse? Now, whenever a right upper lobe collapses, I can summarize the collapse pattern of right upper lobe in one word, and I will say it collapses upwards. How does it collapse upwards? See, this is the horizontal fissure. So if this is the horizontal fissure and the right upper lobe collapses upwards, when it collapses, what will happen? It will pull this horizontal fissure upwards. So this horizontal fissure will get pulled upwards. So the horizontal fissure will go up here like this, and this will be the collapsed lung here. This is how right upper lobe collapse happens. Now, if there is right upper lobe collapse due to a central mass lesion, it creates a classic appearance that is called as golden S sign. Now what is this golden S sign? See, this is the horizontal fissure. There is a large mass lesion which is located over here. This is a malignant lesion. It has infiltrated into the right upper lobe bronchus. So the right upper lobe collapses. How does it collapse? We have just seen. See, it collapses upwards. So it will pull the horizontal fissure upwards, isn't it? So in the lateral half, the horizontal fissure will get pulled up like this. But what will happen in the medial half? In the medial half, right, this mass lesion which is there, it has infiltrated into the bronchus, so it is fixed, it is not moving. It will also prevent the horizontal fissure from being pulled up. So what will the horizontal fissure do? The horizontal fissure will simply drape upon the surface of that mass lesion. So if you look at the shape of this particular, horizontal fissure here, it is concave in its lateral part. It is convex in its medial part. So this concavo-convex appearance, right? This concavo-convex appearance like this is given a name. It is called as the golden S sign. The lateral part is because of right upper lobe collapse, and the medial convex part is because of this mass lesion. So both the parts of the answer are equally important. Why golden? Because the name of the radiologist who elucidated this sign was golden. Therefore, it is called golden. Nothing related to gold and silver here. So this is what is called as the golden S sign. See, now we have seen that the right upper lobe, it collapses upwards. But if I have to summarize in one word the collapse pattern of left upper lobe, I will say that left upper lobe does not collapse upwards, it collapses forwards. How is it so? Look at this schematic image. This is the oblique fissure. Everything anterior to in front of the oblique fissure in the left lung is the left upper lobe, including the lingula. When it collapses forwards, it is going to pull the oblique fissure forwards. So see, the oblique fissure will come and lie over here, right? And anterior to it will be the collapsed left upper lobe, right? So each and every X-ray beam that passes through this particular, lung is going to pass through this collapsed portion of the lung, and therefore look at the appearance. Can you see that there is a wheel-like, this is called as the wheel-like or curtain-like opacity. So curtain-like opacity or a wheel-like opacity is seen, right, throughout or overlapping the left upper and mid hemithorax here, right, and that is what is created by left upper lobe collapse. Now there is a named sign which is associated with left upper lobe collapse, and that is called as Luft-Sichel sign. Luft-Sichel means an air crescent. Now watch carefully. There is again a curtain-like opacity predominantly in the upper part of the left hemithorax. That is because this was a known case of left upper lobe collapse. Now, do you remember in seal-out sign we have studied, if the aortic knuckle margin is not well seen, then which lobe of lung is involved? It is usually the left upper lobe, apicoposterior segment. So we know that when the left upper lobe is abnormal, the aortic knuckle margin will not be seen, isn't it? But look at this radiograph, look at the black arrow. Can you see a sharp aortic knuckle? In fact, there is a crescent of air which is seen lateral to it, right? And this crescent of air which is seen in left upper lobe collapse is called Luft-Sichel. But how is it that in left upper lobe abnormality, the aortic knuckle is seen? Because left upper lobe lines the aortic knuckle. So aortic knuckle should be absent here. The margin should be absent. What happens basically is that because there is left upper lobe collapse, there is compensatory over inflation of left lower lobe. In the left lung, there are two lobes, left upper lobe, left lower lobe. Because the left upper lobe has collapsed, the remaining lobe, that is left lower lobe, undergoes compensatory overinflation. And when it gets overinflated, what happens basically is that the superior segment of left lower lobe, the superior segment of left lower lobe, when it is overexpanded, it comes and lines the aortic knuckle. And because it is lining the aortic knuckle, it creates this sharp margin of the aortic knuckle and the air crescent beyond it. So this is what is called as the Luft-Sichel sign in left upper lobe collapse. In left upper lobe abnormality, one should not see the aortic knuckle, but the aortic knuckle is seen because of compensatory overinflation of left lower lobe. So the superior segment comes and lines the aortic knuckle. That is what creates the sharp margin of aortic knuckle and the air crescent. This is what is Luft-Sichel sign. So the collapse pattern of right upper lobe and left upper lobe is drastically different. Now, how does a middle lobe collapse? Now, middle lobe, is located in between the horizontal fissure and the oblique fissure, isn't it? See, in between the horizontal fissure and oblique fissure. So whenever there is middle lobe collapse, the lung will retract. So what will happen? The fissures will move. Where? They will move towards each other. So you will find that an abnormality, a triangular abnormality like this, right, with two fissures very close to each other. See, can you see? These are two fissures and in between them is the collapsed right middle lobe. Similarly, it gives subtle findings actually on a PA radiograph, but the two fissures, horizontal and oblique, will move close to one another, and that is how it will create a triangular abnormality. Now, there are certain associations which are seen with right middle lobe collapse, and one of such association I want you to know is called right middle lobe syndrome. What is right middle lobe syndrome? It is a combination of chronic right middle lobe collapse, along with a finding of bronchiectasis. So, chronic right middle lobe collapse along with bronchiectasis is called right middle lobe syndrome. Another condition associated with right middle lobe collapse is called as Lady-Windermere syndrome. It is a relatively rare condition. What is this Lady-Windermere syndrome? Lady-Windermere syndrome is pulmonary Mycobacterium avium complex infection. Mycobacterium avium complex infection. It is usually seen in elderly females who suppress this cough for long standing periods, and this basically gives rise to involvement of the right middle lobe and the lingular segment. Right middle lobe and the lingular segment. So it is rare. It is seen. It is a pulmonary mycobacterium avium complex infection seen in elderly females, affecting mainly the right middle lobe and lingular segment. This is called Lady Windermere syndrome. So these are two named entities I want you to know. Now, how does a lower lobe collapse? Now, whatever lower lobe collapses, right lower lobe or left lower lobe, the collapse pattern is more or less similar. How does it create? It creates a triangular wedge shaped density. So where is the wedge shaped density here? See, can you see a triangular wedge shaped density overlapping over the heart there? If the right lower lobe collapses, it will also create a triangular wedge shaped opacity, but on the right side like this. So whether right or left lower lobe collapses, they create a wedge shaped opacity like this, triangular wedge shaped opacity which is there. Now, there are some named signs which are associated with lower lobe collapses. So this radiograph is showing you basically a left lower lobe collapse. There are certain named signs. One is called as the superior triangle sign. Remember that it creates a triangular shaped opacity. So superior triangle sign is seen in lower lobe collapse. Another sign is called as the flat waist sign. So superior triangle appearance and flat waist sign. So flat waist sign is usually seen in extensive collapse of the lower lobes. It is a flattened contour of the aortic knuckle, remember, because of the change in orientation of the mediastinal structure secondary to lobar collapse. So superior triangle sign and flat waist sign, both of them are seen in lower lobe collapse. Now see here, can you see, we have already seen this radiograph once. If you remember, this is what? This is white out lung. Opaque hemithorax, isn't it? Right-sided complete hemithorax is opaque. So what you should look for next? We should look for next is the mediastinal shift or displacement. And if you see here, the mediastinum is pulled towards the same side. So this is very likely to be complete lung collapse. If there is history of surgery, this could also be pneumonectomy. Right? We have discussed this when we solved the MCQ on this as well. So this is either complete lung collapse or this could be pneumonectomy. Yes. Now friends, in this discussion, let us quickly revise the important clinical insights that we have learned. We have learned that fluid is friend of ultrasound. So wherever in the body you want to detect fluid, in this case we discussed pleural effusion, the investigation of choice will be ultrasound. Then we also discussed that air is enemy of ultrasound. So wherever in the body you want to detect air, in this case we discussed pneumothorax. Investigation of choice will not be USG. Air is enemy of ultrasound. So pneumothorax investigation of choice will be CT. This is one important concept that will help you solve many questions. Then we have discussed that you just cannot afford to miss a tension pneumothorax. If you see this hyperlucency with absent vascular markings, always look for mediastinal shift, always look for deep sulcus sign, and if you diagnose it as a tension pneumothorax, remember the first step in the management of tension pneumothorax is a needle thoracotomy to relieve the tension component. This will be followed by the second step of intercostal drain insertion. This is the diagnosis and management of tension pneumothorax. Very, very important condition. In pneumothorax, we have also seen peculiar conditions or peculiar appearances. It is the seashore sign, waves and sand seen in normal cases. And then we have seen this striped appearance, which is called as the stratosphere sign or barcode sign. Yes, so these are M-mode ultrasound findings, right? This is something that we have seen. And we have seen various lobar collapse patterns and signs. Can we match them up quickly? These are few signs that we have already seen. Can we match them up? So golden S sign, I told you, when the horizontal fissure is pulled up, so it will be seen in upper lobe collapse. So golden S sign is seen in the right upper lobe collapse due to a central mass lesion. We have discussed this in detail. Juxtaphrenic peak sign. Yes, so this is something that is new. See, what happens basically is that whenever an upper lobe collapses, what happens is that because the upper lobe has collapsed, right, it creates a more or less of a pull on the lower structures, that is the lower lobes and the diaphragm towards the upper side. So whenever there is upper lobe collapses, right, there is a small peak which is seen along the diaphragm sometimes, and this is called juxtaphrenic. Phrenic means diaphragm. Juxtaphrenic peak sign. So this peak, right, which is created, right, in an upper lobe collapse, right, along the diaphragm because of the pull, upward pull because of the upper lobe collapse, is called juxtaphrenic peak sign. So any upper lobe collapse, be it right upper lobe or left upper lobe, on the ipsilateral diaphragm, it will create a juxtaphrenic peak sign. Luft-Sichel sign, do you remember? Luft-Sichel means air crescent. It is seen in left upper lobe collapse due to compensatory overinflation of the left lower lobe. So Luft-Sichel sign is seen in left upper lobe collapse. Superior triangle sign, lower lobe collapse, usually gives rise to a triangular wedge-shaped opacity, and that is what is superior triangle sign. And Lady Windermere syndrome, we have seen pulmonary Mycobacterium avium complex infection in elderly females who suppress cough, affects the middle lobe or lingula. So Lady Windermere syndrome is usually right middle lobe collapse. So these are various signs that we have seen here. We have just matched them up. So coming back to the clinical quiz, see here now, this should be easy. Patient presents with breathlessness, pedal edema, basal crept. So this is congestive heart failure. There is a mass-like opacity which disappears on the third day. So this is called vanishing lung tumor, phantom lung tumor, loculated pleural effusion which has resolved. We have discussed this history clincher as well as imaging clincher. So what is this therefore? This is loculated pleural effusion within the horizontal fissure which has disappeared after treatment of the underlying cause, that is congestive cardiac failure. Yes. Now look at this. We've already seen this radiograph. Visceral pleural line, absent vascular markings, hyperlucency with absent markings. Patient has an acute presentation with onset in difficulty, elevated respiratory rate, BP is normal. X-ray suggests we have already seen unilateral hyperlucency, absent vascular markings. Mediastinal shift is there. So what is the diagnosis? Diagnosis we have seen is tension pneumothorax. Right? And what would be the first step in the treatment of tension pneumothorax? It is a life-threatening emergency. First step in the treatment is needle thoracotomy to relieve the tension component, right? And then ICD insertion. What is this image? See, classic. These are the waves. This is the sand. So this appearance seen in a normal patient. They have given you a clue on M mode ultrasound, right? So this is typical. This looks like a seashore. So this is what is called as the seashore sign.